Right, I'm here today with Jonathan Hill. Hello, Jonathan.
Hi, Rachel. Nice to meet you.
Nice to meet you too. Thank you so much for joining us today. I'm hoping to talk a little bit today about low back pain and managing individuals with back pain. But before we start, I was hoping that you might be able to just introduce yourself and tell us all a little bit about what you do and how you came to specialise in low back pain, if that's what you do.
Sure. So I'm a senior research physio at Keele University. I work in a primary care research centre there. So alongside a whole range of different clinicians, so GPs mainly because it's a primary care research centre, epidemiologists, statisticians, health economists, and there's occupational therapists, and it's a really multidisciplinary group. I've been there since 1999, so quite a while now. I qualified, I trained in Manchester
As a physio.
as a physiotherapist, and I qualified in 1994. And I've got a wife who's a physio who I trained with. So yeah, we worked all over the place in Stoke-on-Trent. I did my junior rotations. We went and worked out in India for 6 months as volunteers, worked in Australia and did some locuming all over the place. Really enjoyed ourselves, and then settled back in the UK in 1999, having worked in a number of places. And it was then that I was working initially in Derby, and then I took a research job at Keele, and I became a research assistant for Professor Krisha Jejits. She's one of my great colleagues who had got a trial funded to look at patients with neck pain. Should we be giving them manual therapy in addition to advice and exercise? And was it helpful also to give them electrotherapy in terms of pulse shortwave diathermy? So that was my first introduction to research, and I went on from that trial to do an acupuncture trial as a trial coordinator. And then after that, I started my PhD and completed that in 2007, 2008, when I graduated. And that was all about the STarT back tool, developing and validating that prognostic tool. We did a pilot trial looking at whether the match treatments were feasible in terms of the training of clinicians, and did patients like it. And I went on from there to help with a clinical trial that was the STarT back trial. And so I've really been at Keele for quite a while, and we've now involved in, I sort of sit between, I do clinical trials, but I'm very interested in clinical tools and the epidemiology that helps us to develop good clinical tools. And so I sort of bridge the gap between the epidemiology team and the clinical trials team. I'm principal investigator for a study looking at a new evaluation tool, a patient-reported outcome measure for musculoskeletal patients. And I'm doing that study in collaboration with Oxford. And that's all about how do we evaluate our services, how are we going to in the future benchmark our clinical outcomes, how do we help patients to monitor themselves, and what else do I do? And then I'm principal investigator for a new stratified care trial, which is very similar to the STarT back trial that I guess you'll be asking me about. And that's all to do with this stratified care approach. And is that helpful for patients with a range of musculoskeletal conditions, not just back pain?
Is that the IMPACT trial?
No. So the IMPACT study was one that Nadine Foster led, and that was an implementation study that took the STarT back trial as a proof of principle and said, okay, we apply that now in general practices, and we get your routine GPs to use the tool, and we get the services, the physio services that those GPs use. If we get them to deliver pathways according to the stratified care protocol, does that help in real life busy clinical practice? So that was very much an implementation study. But yeah, that's all complete, and that's available in Annals of Family Practice. Nadine's the first author, and she was the principal investigator for that study.
Okay, so the other study that you were just talking about, doing a prognostic tool for musculoskeletal conditions?
Yes. Yeah, so that's a new 5-year program of research that we've been funded at Keele. And in the first work package of that, we have to develop and validate this new stratified care tool that will work for necks, shoulders, knees, backs, as well as multi-site pain. And we've just completed our cohort study of around 1,800 patients that is allowing us to validate that. One of the tricky things there is that what we find is that the prognostic indicators are fairly common across different conditions. But if you're not careful, the tool cutoffs that allocate people to, say, medium risk or high risk, they vary, whether it's a neck or a back or a shoulder or a knee, because of the item. So when we tried to just modify the STarT back tool to see if that would work for someone with a shoulder problem, what we found was some of the items are quite back specific, such as a walking item doesn't affect someone with an upper limb problem. And so the tool, the cutoff that we were finding was the optimal for patients with different body regions that was affecting them were different. So we couldn't get a consistent cutoff. And we just don't feel that GPs, that it's practical to have a tool that's going to have lots of different cutoffs. And particularly so many patients come with more than one presenting problem, and things change, don't they, over time? So we're going for this new tool, and at the same time we're working up the new matched interventions. So if you think about a knee patient, low risk, medium risk, high risk, what would the matched pathways look like for those patients? If you think about a shoulder now, what would those look like? So one of my colleagues, Joe Prothero's leading that, and we've been working through a whole process of, it's mainly been looking at the evidence, getting clinical experts together and trying to develop very clear pathways that are different for low, medium and high risk patients for primary care. And that's all coming towards an end now, and early next year we'll be starting the pilot study, and that'll be looking at is it feasible to run this, well, to train the GPs to use this new tool and to get them to do the match treatment options, and then that'll move hopefully into the main trial in the summer next year.
So I would love to talk to you more about that, but I think we should probably save all of that, so the other conditions, for another day, so maybe next year when you start that trial. But that sounds really interesting, and I'm really excited to see the outcomes of all of that. But taking it back just a step, could you tell me or tell us a little bit about your work on the STarT back tool? For people that, I know that there will be some people out there that haven't heard of the STarT back tool. I know it's very commonly used in the UK, which is where we are, but obviously it's not used everywhere. So if you could just explain to us a little bit about the STarT back tool, what it is and how it's used effectively, I guess.
Okay, so the STarT back tool is a prognostic tool, and it's used epidemiology, so big cohort studies that have been done in the past to try and identify key prognostic factors. We've used that information to work out, okay, these seem to be key clinical factors that we can measure early on in patients that will help us predict their outcome 6 to 12 months down the line.
Individuals with back pain.
These are individuals with back pain presenting to primary care. So in the UK, that's general practice on the whole. So that was the context, or the sort of underpinning work that we had that helped us identify the constructs that were important. And we had to go through a process of working out which were the constructs that were really consistent across different studies, and which ones as well were modifiable by treatment. Right from the outset with STarT back, we decided if the tool was going to be really useful for clinicians, we wanted to give them a sense of the risk of an individual having a problem, but that was treatable. Identify factors that you could modify as part of your treatment, so that we weren't just picking up people who'd had their problem for 20 years, they're going to have them 21 years, and you can't really do anything about that episode duration. Whereas if it was around the severity of their pain or around their functioning, factor associated with their level of fear, for example. Those things you could address and you could seek to try and tackle as part of your treatment. So the StartBack tool only includes modifiable prognostic factors, and we had to work out a way of getting this tool very simple, very brief, so that it could be used in very short consultations, which general practitioners have. And our focus was general practice, although we were very conscious that it's not only general practice that are the first line practitioners in the UK. I mean, physios, often chiropractors, osteopaths, all have a role in that early decision making for patients with back pain. So, but it was that knowledge about GPs, particularly with the very short consultation that they had, that led us to try and develop a very brief screening tool that would help us give a score to an individual that would inform your decision making about what's the likely prognosis for this individual, and that would then help you make a better decision about what was the appropriate treatment for that individual in that early, initial contact with them. So we went through a process of developing that tool, working out with patients what were the best single items to capture key constructs, such as fear, catastrophizing, comorbid pain, referred leg pain, all those sorts of things. So it's not just a psychological or a psychosocial screen. It's very much what's the overall impact, and it covers the full sort of biopsychosocial spectrum, some physical constructs and some psychosocial constructs. And we ended up with 9 questions, and we used our data to tell us where the cutoffs were, with low risk patients being those that we could be confident that their prognosis was good. Medium risk, these patients, their prognosis was now looking, on the whole, the majority of them would have a poor prognosis. And then high risk really was to identify those with more complex problems, particularly those who are more psychologically distressed, those who were more fearful and anxious and depressed, so their mood was lower. And we used clinicians very much to sort of help us to try and determine where those cutoffs should be, particularly for the high risk, whereas the data much more was driving, it was telling us which patients had a good and poor prognosis. So that was helping us to determine the cutoff for medium risk. And we went through a process of checking it out on one patient cohort and then having a second independent sample to check that things were working and the cutoffs were still working well in that second group. And that was all part of the PhD as well as the pilot trial that we ran. And Elaine Hay was the chief investigator and was my PhD supervisor, and was excellent in terms of moving us from just sort of that tool development work to seeing the vision for the trial that would really prove if that was an effective approach to use in primary care. And that's where we moved from that work then on to a clinical trial.
So listening to you talk about it, it's, and as any piece of research is, it sounds so involved and I hasten to say complicated, but it sounds involved and complicated, but you've done such a good job of making such a simple tool that clinicians can use. Like you say, there's just 9 questions and it's really easy to use. So for anyone that's listening that's thinking, oh, that sounds a bit too much for me, it's a really simple tool and really easy to use in the clinic. With patients, which is great. And then what was the outcome of the clinical trial?
So the clinical trial was a proof of principle trial, and we were looking to see whether if we use this approach of stratifying patients using the tool, were we going to really improve particularly physical function? And we used that, or something, the Roland Morris Disability Questionnaire, to assess that and evaluate that. And the tool showed that on our primary outcome, which was at 12 months, we also looked at a shorter term outcome at 4 months, that we were getting statistically significant improvements in patients' function when they were allocated to that treatment arm rather than to a usual care. So there, the usual care, you had physios that were looking at patients, evaluating what they were going to do with them, but they didn't have the tool available to them. So they're using their own clinical intuition to decide what the best thing was to do with an individual in front of them. Whereas in the active arm, those clinicians had the tool and they very quickly knew if this person's prognosis was low, medium, or high. And there were these matched pathways that they were, and they're very broad pathways. They don't tell you how to treat the individual. They just tell you that this person's at low risk. So with those sorts of patients, we try to encourage self-management. You don't over-investigate. You don't over-medicalize those patients. And you don't over-treat them, because often we find low-risk patients are getting a lot more treatment than they really need. And then for the medium and risk and high-risk patients, you really are wanting to treat them right from the beginning. Often people are tempted to go back to what I call a stepped care model, where, well, we'll just check you once again in a few weeks and then we'll make the decision. And I think what we've shown is that, unfortunately, with that, you get patients who have slipped through the net, and as a result, you're actually better, and it's cost effective to right from the beginning say, okay, this is your risk status at the beginning, so let's send you for some treatment. And it's up to the physios then how many times they see you and what they do with you. But it just prevents those patients from falling through the net. One of the key things that we had to do was we had to upskill the clinicians to feel confident to treat the complex group, because what we found was, when we said to the physios, you're going to be treating this high-risk group who are quite distressed, they had some concerns about that, and we had to work with the physiotherapists to say, okay, well, where are you feeling less confident? Is it the angry patient? Is it the patient whose mood's in their boots? Which sorts of patients are you going to need help to feel more confident? Not training them up to be psychologists, but to help them to be informed about what assessment skills, treatment skills they could have that would help give them a confidence about how they might manage those more complex patients and those more difficult issues. And we found it was mainly based on good communication, strong therapeutic relationship, but really skills around taking some of the key bits from cognitive behavioral therapy in terms of assessing the patient's cognitive, behavioral, social aspects, and trying to work out, okay, so what's the impact and their response to the pain that this individual's having in terms of that cognitive and the emotional and the behavioral, and which bits really are related to the pain, which bits aren't related to the pain, which bits are modifiable by the patient and by me as the therapist, to really sort of be able to get under the skin of the patient, and then put a management plan together to help them. So that's where we went with the high-risk training. It was a 9-day training course, actually, so it was quite long, but we really got our qualitative findings really showed that the physios felt much more confident about treating those high-risk patients once they'd been through the training course. And sure enough, what we found is that they were better at treating some of the more psychosocial issues, and we saw big changes, significant changes in those patients that had the stratified care, and saw those physios that had that extra training. It's still a very contentious issue about the extent to which physios should be doing hands-on, hands-off, and I think we've tended to swing from a only hands-on to there's been a big push for hands-off. And clearly I think what I would advocate is that we need both. We need good hands-on skills, but we also need to accept that some constructs, self-efficacy, fear, catastrophizing, do seem to be important predictors of outcome, and where they're key barriers to helping someone recover, we need to have some skills to be able to address those, and where we're not helping someone, be able to monitor, detect that, and signpost them elsewhere to someone who can manage them, so that patients don't slip through the net. And I think what we found in the STarT Back trial was that it just nudges everybody in terms of being systematic in decision making to ensure that to overall lead to a result which is important for the whole population in terms of improving patient outcomes. I think partly what's happened is that we had an embedded health economic evaluation, and a lot of managers and a lot of people have seen that and read that, and part of the interest around STarT Back has been around the fact that people see it as an opportunity to make savings, and which is a little bit disappointing because it should be the clinical benefits to patients that drives change. But yeah, the reality is that the costs are important too. And stratified care is about making healthcare resources more efficient and just helping us be a bit more consistent, a bit more systematic in how we make our decisions, informed by prognosis. The tool's not perfect in any way. 9 questions, yes or no, does not always accurately identify a prognosis for an individual. But overall, the trial would suggest that it helps improve outcomes and it's a cost-effective approach, even though slightly more patients are going to get treatment, actually, because you get slightly more people identified for treatment than you would just if you used clinical intuition alone. And we saw that replicated in that impact study that you talked about, where GPs rather than physios were using the tool. And a very similar finding that, what we saw was that reduction in number of treatments for low-risk patients and a sort of a steer towards let's be a bit more proactive with these at-risk patients, these medium and high-risk patients. And that just nudges everything along. And it means that those medium and high-risk patients are less likely to seek secondary care or be referred to secondary care, less likely to take quite so much medication, less likely to have time off work. All sorts of other spin-offs come from the fact that you've identified them right at the beginning and you've sent them through to the right person. So it's all about just getting this supply chain right so that, so that those patients are being seen by the right person at the right time, which is a strap line that I guess is great when it actually happens.
Yeah, well, that's what the StartBack tool helps with, isn't it? It's so effectively it's a prognostic tool, so assessing individuals with the StartBack tool, which is a 9-question tool, assessing them to give them a prognostic sort of outcome, and then leading them into a broad pathway of care where the individual therapist can make decisions to individualise the treatment for that person. Would that be right to say?
The only qualification is that people very quickly see the stratified care approach as being about the tool and only about let's allocate them as low, medium or high, and then we've done our job. And really the trial doesn't allow us to say whether it was the tool bit or whether it was the upskilling of the clinicians to better manage the high risk. So we have to recognise that actually the clinicians that were treating high risk did a much better job when they'd had that training. So there's clearly something happening there. There's also clearly something happening about getting the right patient to the right person and down the right pathway. And it's a mix of both. And unfortunately, the research design that we were using doesn't allow us to really unpick particularly which of those two elements is the strongest. And I don't think that probably you could do one without the other. I think you have to have both together.
Yeah. You've mentioned stratified care a lot. Can you just clarify for me, what is stratified care?
Well, you and I would have always in the past spoken about subgrouping so that we could target treatment. And stratified care is really just different terminology, different language for subgrouping in order to target. The slight difference is that there is a literature around stratified care which is all about that healthcare efficiency and how do we use our resources. And so I see stratified care as being something which is just, it helps us position our research within that wider context and literature to talk about stratified care.
Okay.
So that's very much where we've gone as a team.
Yeah, I think that makes total sense. If when you put it like that, that's really quite helpful, and I think that'll be helpful to a lot of people. That simple explanation. So, in the WCP symposium on low back pain, you and your colleagues talked about this stratified care approach to low back pain. Where do you see the StartBack tool sitting with those other approaches to subgrouping and how can they work together? Because Mark obviously talked at the end about how all the different approaches to subgrouping. Wouldn't it be great if we could get them all into one package?
Wasn't it fascinating when he presented that slide and all the cameras came out across the whole conference and everyone took a photo of it? Clearly, there's huge interest in can we combine approaches, and I think that makes sense. I think in the future that's where we've got to go. We've got to get some research to say, is it possible? The STarT back tool is very much helping to get the supply chain right. And yet, other ways, mechanisms-based approaches and the treatment classification, the more American approaches, they help really tailor the treatment to the individual. Whereas I don't see our STarT back tool as particularly helpful with that. So I think a combination intuitively makes sense. I like it as a clinician. It seems to be a good direction of travel. But as a researcher, I don't have any confidence yet in whether that would be effective, whether it be feasible in terms of being able to train people to do it in a reliable way. So I think we've got to do the research. I would say that as a researcher, but that's well, the only problem with that is that could lead us into pitfalls, and we could end up with going down blind alleys or doing things which are unhelpful. So my cautious side would be saying, let's get some pilot studies done and then move to main trials where we're seeing something that looks promising. And I know that there's a group in Finland that are looking to do a trial they've submitted for funding, which combines a STarT back approach and Peter O'Sullivan's classification approach. And we'll have to wait and see. I think we hear at the end of September whether that's been funded. And I would love to work with Julie Fritz maybe and others, colleagues in the US, to see if we can find a proposal that would work around their classification system in combination with a stratified care STarT back tool like approach. So I think it's something that's certainly on the horizon. And we've just got to work through and find funding. It's not easy to get research funding, as you know, I'm sure. But if we can, that's a future direction of travel.
I think it's really exciting. I also think it's huge to be taking all of that on and trying to work through all of that. So in advance, I congratulate anyone that takes that on. Yeah.
One interesting trial that we have had funded at Keele, I don't know if Nadine has spoken about that when she was interviewed, but it's called a SCOPIC trial. And what the SCOPIC trial is doing is stratified care, but just for patients with sciatica or suspected sciatica. So those with where the GP thinks this patient's got back pain, has got some referred leg pain, those patients would be eligible for the trial. But it's an interesting iteration on what we've done before, because we're using prognostic information plus some key clinical signs, key clinical indicators, which are used as an algorithm together to then to help send people down different pathways, where low risk is again encouraging self-management, medium is physio, but high risk this time is more focused on getting an early surgical opinion or medical specialist opinion about whether potentially surgery might be helpful, and they have an MRI on the way to getting that, and that's the principal investigator for that at Keele's Kika Constantinou. That's a very interesting study that's now underway, recruiting patients fast, and hopefully in a year or so we'll be getting the results for that and be able to tell the world whether that's an effective clinically and cost-effective approach to use for those specifically with suspected sciatica.
So it sounds like we might be going down the way of, so we see the individual with low back pain comes in and we assess them first of all for their red flags and anything that stands out, and then if we're still okay to carry on, we group them into either the leg pain group or the non-mechanical back pain group, and that will direct whether they go down the STarT back route or the Scopic route. It sounds like there becomes a junction at that point.
Yep. And I think up to now, that's where the guidelines already would suggest that there does need to be a difference in how we view those with a suspected radiculopathy from those who haven't. And I think where there is a clear diagnosis, maybe they're a stenotic patient, the diagnosis will lead the pathway. But then for that large group with non-specific back pain, the diagnosis isn't the thing that's really leading the pathway, and there maybe prognosis is particularly helpful in determining the level of resources that we throw at that individual, to make sure that they don't slip through the net and end up in lots of persistent chronic problems down the line.
Interesting. Well, look forward to hearing the outcome of the Scopic trial as well, to build on all of this. Now, you're not a clinician anymore, you're a researcher, aren't you? So, but
I've moved over to the dark side.
Yeah. But I do want to ask you, if you don't mind, what do you think, when we, as clinicians, when we have a individual with low back pain coming through the door, what are the things that we should be thinking about as we go into that assessment with that individual? What are some of the most important things that we should be thinking about for that assessment?
Oh, there's a challenging question. My take is that we need to be broad. So that one of the things that we've got to clearly do is we've got to question the patient thoroughly and do the normal subjective history, but be prepared not to jump too much onto our particular, we're all good at pattern, well, clinicians particularly are great at pattern recognition, and it can be very tempting to go, right, I know what this is, I've seen one very similar, and to just see it as the bio and the pathology that you've kind of is your working diagnosis at that time. And I think one of the things that I've found I've done as I've talked about STarT back all over the place is been to really bring that emphasis of, don't forget that you're treating the whole person, and that particularly when you're treating a more complex individual, that there might be other issues going on which the patient is a little bit reluctant perhaps to reveal, but it's easier for them to tick on a questionnaire. And we very much have taught what's called a stem and leaf approach, where you probe across key areas, maybe work, maybe social activities, home life, and to get a sense of, is this person, are they having a meaningful life for them at the moment? And if they're not, why not? And try to sort of uncover where those barriers and those issues are. Is it around unhelpful beliefs, unhelpful behaviours and patterns they've got into? And where among those different things are you able to bring some wisdom, some care, and help shift them out of that? And often the patients will come with some solutions, but they just need your support and encouragement to just nudge things back into a healthy direction. So I find myself often just saying to people, just remember to be broad. Remember to ask about the sleep, about the medication, about their previous history. So often patients are confused about our healthcare systems, and we understand it, and we presume they understand it, but often they don't, and they've seen 2 or 3 other people who've given them very different messages. And, those concerns naturally build up. And we have to be careful we just don't label people, but that we're prepared to take them for who they are, really understand them, and then bring that care, that expertise that we have, to be able to put a management plan together that's going to address all those different areas that we can, to get this person now on the right road to recovery.
So I think what you're highlighting there is the importance of the subjective examination, or the patient questioning, the patient intake, and the importance of communication and including expectations, patient expectations within our assessment.
But I wouldn't want to in any way say that the differential diagnosis, the clinical examination is less important. It really isn't. It's just that what we've found, I guess my STarT back experience has told us, that when it comes to treating those more difficult patients, our area of weakness is not on the diagnosis, because we've got so many courses, we're so good at that as physios. It's more around some of the more tricky areas, the psychosocial things, where we've traditionally lacked a sense of confidence. But I do think it depends on the individual. I think there are some clinicians out there who perhaps need to do less of that, and they do need to get better differential diagnosis skills. And there are others who it's the listening and really communicating well that's their weakness. So I do think it depends on the clinician, absolutely, and it depends on the clinical context as well, because I think we all work or clinicians work in a particular clinic, and they see a certain group of patients, and they tend to think all back patients are like the ones that they tend to see, and yet that's not always the case. And I'm often reminded by a friend of mine who's an osteopath, who 80% of what he sees is probably low risk. It's very different to another friend who works in a pain clinic, and 80% of what they see would be high risk. So we all see a different spectrum of patients, and some of the arguments that occur in our profession between the hands-on and the hands-off group are partly because they're seeing slightly different sorts of patients in their routine care.
That's a really interesting perspective, actually, and from my perspective of the people that we Physiopedia, from our users and participants on the courses and things, it'll be completely different for the people in the UK and the US to the people in Africa and and Asia, where they just completely different. So it'll be really interesting to have a discussion around that on this course, and be interesting to see those sort of outcomes.
It's been fascinating for me as a researcher to see how STarT back has caught the imagination of people in very different countries and with very different care settings and systems. And one of the key things I guess I'm always concerned about is, will it work, in Japan, or would it work in Argentina or Finland? So far, the tool seems predictive across the different settings. But one of the things that we do need to really check is, are the cutoffs optimal for different countries? And there's still lots of research to be done, and we haven't had the replication studies anywhere other than, the UK is the only place that we've done it. So this is early days for stratified care, and we really need those extra research studies to look at their results to say, okay, are we seeing a consistent picture across the world here? Or is stratified care something that's particularly helpful for the UK? Maybe we're particularly poor at early decision making, I'm not sure. My sense is possibly, I'm hoping we'll find it's even more effective where the care systems are slightly skewed for whatever reason, because of the fact that people are getting paid for ordering an MRI for their patient or whatever, and that we might find it's even better in those sorts of settings. But we need to wait for the results and see.
So if anyone's listening that wants to do a replication study in their country, then contact Jonathan.
Please do.
Yeah. So just one last question. I'm aware of the time. One last question, which is quite open-ended. And what about the future for low back pain and management of individuals with low back pain? What would be your initial thoughts on that question?
It's a really good question. I think we need to start looking at where we've had blind spots. So treating elderly people, back pain. I know that Professor Sally Lamb's doing some research on that, and there's a lot of work that really needs to be done in that area. I think we need to look at how do we help people stay at work, and there's some good research that's starting to be done, particularly in Scandinavia, where they've got some trials at the moment looking at training physios to really help with the vocational rehab side of things better. And I look forward to seeing those results. I think we've got to be careful we don't throw out our real investigations about understanding the pathology better and looking for treatments there, because there's been this big push for the psychosocial side of things. And yeah, it excites me that it's such a broad, complex. Back pain is complex. There's not going to be a single answer. We're going to need a range of different people with different research angles coming at this topic to try and move things forward. And my sense is that there's a lot of exciting things coming up in the near future. And yeah, we just need to keep going and seeing, piece by piece, let's try and work out if we can improve the lives of patients who suffer from back pain. I don't think there will be one solution. I think I've just said that probably. It's going to really be a mix of different things. Do antibiotics work for that chronic group? We've got a trial that we've just submitted at Kiel, which will be a replication of Hannah Albert's antibiotics for those with modic changes trial. That's an exciting area. There really are lots of different areas, I think, and let's see where the research goes and what it tells us over time.
I'd be very interested to see a study on nutrition as well in relation to back pain.
Yep. I don't know if anyone's working on that, but yep, you're right. There's certainly, I noticed at the Mackenzie conference that was something a lot of people were asking about.
Oh, interesting.
So it's clearly something clinicians at the moment are interested in.
Yeah. Okay. Well, thank you very much. Are there any final messages that you would like to add to the conversation? I think we've covered a lot. We've talked about the STarT Back tool. We have a really good understanding of that now. Interesting to hear about your research and where the future might go. So is there anything else you'd like to add to the conversation, or any other little snippets of advice you might have for anybody?
I don't think so. But thank you for interviewing me, and yeah, I hope that's been helpful to people to hear.
Most certainly very helpful. So thank you very much for your time today, and we look forward to your research in the future.
Thanks, Rachael.